Hello, my name is Katherine Sommers, and I am a third-year medical student here at Wayne State University School of Medicine. Today I will be discussing an interesting psychiatric consultation I was lucky to see with Dr. Patars and the rest of the care team. Our patient is a 58-year-old black male with a past medical history of major depressive disorder, schizophrenia, and stimulant use disorder who presents to the VA-ED complaining of bugs on his skin. The patient had last used cocaine the day before admission. He states that cocaine use makes the bugs worse, but that the bugs are present whether he is actively using cocaine or not. He states he first started feeling bugs crawling on his skin and burrowing into his skin about 2 years ago when he purchased cocaine off the street. He states that this cocaine was laced with very advanced technology that entered his body and took control of his senses. He states that the people behind this advanced technology send him voices from a device that combat his thoughts and control what he sees, feels, and hears. He also believes these people put bugs behind the speakers in his car, which has caused him to remove the speakers and the seats in his car. He endorses auditory hallucinations that instructed him to come to the hospital today and to watch out. The patient proceeds to show the staff a small mole-like lesion on his arm that he believes is where the bugs entered his skin. Upon reviewing systems with the patient, he endorsed pruritus and tactile sensations on the skin. Otherwise, all other systems were negative. As stated previously, the patient has a history of MDD, schizophrenia, and stimulant use disorder. He also has a history of hypertension, osteoarthritis, CKD stage 3, glaucoma, OSA, and BPH. His home medication regimen, which he is currently non-compliant with, includes profenazine 4 mg daily and risperidone 2 mg daily. The patient has no family history of mood or psychotic disorders, but his father had alcohol use disorder. The patient has a history of houselessness, but is currently living with a significant other. He is a current tobacco user and smokes a quarter a pack a day. His history is positive for mild alcohol use, occasional marijuana use, and cocaine use. He has had no history of suicide attempts. He has been admitted to the inpatient psych unit at the VA 3 times prior. The patient is afebrile and vital signs are stable on room air. A complete blood count and a comprehensive metabolic panel were drawn in the ED and are unremarkable. His urine drug screening is positive for cannabis and cocaine. His physical exam is unremarkable with no evidence of parasitic skin infection. Objectively, we determine this patient is a 58-year-old black male that appears younger than the stated age. He exhibits poor grooming and hygiene as well as unkempt facial hair. He appears to be in no acute distress, and he exhibits no psychomotor agitation or retardation. When asked about his mood, he states that he needs help. His affect appears euthymic, but at times agitated and anxious concerning ongoing delusions. His thought process is linear and organized, but illogical and bizarre. His thought content consists of abnormal, psychotic thoughts and delusions. He endorses auditory and tactile hallucinations, as well as delusions of reference, thought blocking, and thought insertion. He denies suicidal and homicidal ideations. He appears awake and alert, and he is oriented to time, place, and person. He exhibits poor insight and poor judgment concerning his psychiatric conditions. So, given the patient's unremarkable objective findings and the patient's psychiatric history, the emergency department consulted psychiatry about this gentleman. So now is a good time to run through the differential diagnoses our team had upon seeing this patient. So this patient was endorsing a slew of delusions and hallucinations, but what was causing him the most distress was the false belief that he was infested with insects. This phenomenon is called delusional parasitosis, and this can occur as a primary diagnosis or secondarily to many disorders. So with his past medical history of schizophrenia, we first considered the patient was experiencing an acute psychotic episode in the context of his chronic schizophrenia, and this acute episode was most likely due to medication non-compliance. Next, it's super important to consider that the patient is experiencing formication due to stimulant use disorder, specifically due to cocaine use and withdrawal. Formication is defined as tactile hallucinations that mimic insects crawling on and under the skin. The word formication comes from the Latin word formica, which means ant. So next, we considered the patient had new onset primary delusional parasitosis, but we actually shied away from this being his primary diagnosis, just given his comorbid conditions. Finally, we wanted to do our due diligence and definitively rule out the possibility of a skin infestation with scabies or body lice, which is totally possible given his history of living in crowded conditions, such as homeless shelters. The reason why we shied away from this was because the physical exam was unremarkable and he was currently living in a home with just his significant other who was not experiencing any tactile sensations. So we decided to treat our patient's complaints under the impression that this was most likely a manifestation of an acute psychotic episode in his otherwise chronic condition of schizophrenia. The patient had not been compliant with his antipsychotic regimen. He was displaying illogical and bizarre thought content and had multiple positive symptoms besides delusional parasitosis, such as thought blocking, delusions of reference, and auditory hallucinations. So we operated under the assumption that his tactile hallucinations that he believed were bugs infesting his skin could have been due to cocaine use and or withdrawal. But it's important to mention there's no FDA-approved treatment for stimulant use disorder besides counseling and abstinence. So while on the unit, we started the atypical antipsychotic risperidone 2 milligrams daily, which was well tolerated. So we titrated up to 4 milligrams twice daily upon discharge. The patient was also started on the high potency typical antipsychotic, perfenazine, 4 milligrams daily, and the sedating antihistamine, hydroxyzine, 100 milligrams at night. Hydroxyzine works to both curb anxiety and pruritus in this patient. So he was stabilized in the inpatient unit and was planned to follow up on an outpatient basis. Thank you for listening.